My case is a 70-year-old hypertensive diabetic and dyslipidemic female who presented to us with typical chest pain. ECG showed STD depressions in anterolateral lids, positive troponin, regional wall motion abnormality in the lateral wall of LV with the EF around 40%. Considering the higher risk, we took up for early angiogram and it showed triple vessel disease, calcific and critical LMCA trifurcation. We have a heart team at our hospital, so we gave this case to the heart team and they recommended CABG, but yes, the patient boldly rejected the proposed plan. So this was the angiogram. As we can see, the left main distal had quite a lot calcific disease. There was calcific and critical ostial LAD, ostial LCX, and ostial ramus lesion. The distal vessels were reasonably sized and of fair diameter, but the patient had rejected the plan of CABG. The RC also had moderate and calcific disease in the mid part. So we had few problems in this case. The patient had triple vessel disease with left main trifurcation disease. The lesions were calcific, they were ostial in location, angulated and little tortuous. The age of the patient was more than 65, she was slightly frail, eGFR was around 60, and she was resistant to the advice which was given by us in fact. So plan, we decided to address the left system because the right system only had some moderate to severe disease, but moderate disease, we decided to address the left system first. We knew that we required a proper lesion assessment because it was not going to be easy, and preparation using proper tools. We wanted to ensure the patency of both RI as well as the circumflex because both of them had fair size and in fact a fair myocardial supply as well. So as we knew that we had 3 vessels up front, we decided to go ahead with the 8 French guide. The wiring of the LED was tricky. The origin was, a little angulated. We required, in fact, the support of a microcatheter and a hydrophilic wire. We then decided to assess the lesions, but IOS could not be negotiated to the angulated LED, the calcific LED, and we were not able to even cross the 1.5 mm semi-compliant balloon. So we exchanged the routine wire, hydrophilic wire with the rota floppy and went ahead with the rota to LED with the 1.5 mm burr with multiple patient runs. In fact, there were 14 to 15 runs which were very slow. We were very careful not pushing through. We usually use our fingers, keep the wrist locked at the rota console. After the initial rotablation, we dilated the distal LMC and the LED with the 2.5 12 NC balloon. The calcium gave away, giving a space in the LMCA polygon and the LED so as to pass the IVUS. We went ahead with the IVUS, which showed heavy concentric calcium in the proximal LED and the polygon with a sizable but diseased left main. Also, there was dense eruptive calcium in the ramus with a nodular protrusion into the lumen. And this useful piece of information from IVUS helped us in further preparing the lesions of ramus with rotablation and cutting balloon. So with that handy information from IVUS, we realized that we won't be able to just get away with balloon dilatation in the ramus as well. So we exchanged the routine wire in the ramus with the rota floppy, went ahead with the rota to ramus with a 1.5 mm burr. Again, going very carefully, not pushing any through because we knew that there was that eruptive calcium. If we force very hard, it could result in perforation. Following that, we did a cutting balloon dilatation with Wolverine 310, both sequentially in LED and RI at 14 atmospheres each. So this was the bed preparation done with the strategy of upfront bifurcation. We decided to go ahead with the cullet to RI and LED bifurcation and a provisional approach to the LCX. So we wanted to ensure that the LCX is also not closed. We first stented LMCA to RI with a 3.522 resolute, did a port in the left main with a 5.8 NC balloon, and then crossed into LCX and secured ostium by dilating with a 2.0 semi-compliant balloon. So after seeing that the LCX ostium is fair enough, we then recrossed to LED and then stented from LMCA to LED with a 3.538 resolute stent. After that, it was, since the bed was well prepared, we were, going fast now. We did a port again in the LMCA with a 5.8 NC balloon. After ensuring that the LCX is flowing and, its flow is not disturbed, we recrossed carefully into the RI. Struts were opened up gradually and then did a kissing balloon inflation in the LED and RI with a 3.5 NC balloon each, followed by a final port in the LMCA with a 5/8 balloon. So finally, we got a fairly enough result after a fluoro time of almost 50 minutes, a contrast volume of 150 ml, and a radiation dose of 1,500 milligray. We could, secure LMC, LED, and RI well, and I was showed that the stent expansion was fair enough. There was a fair MSA, and in fact, there was also flame maintained in LCX and the high diagonal. So my take-home message is very simple. We understand that provisional approach is suitable for many bifurcation cases, but yes, you do require to have a upfront two-stent approach in your mind when you are dealing with patients having complex calcific and trifurcation anatomy, especially when the side branches are supplying a large myocardial area. In each case, the choice of bifurcation technique should be determined according to the specific anatomy of that particular case, and of course the operator and that center's experience in a particular bifurcation technique. Understanding the lesion type, the extent of the disease, along with the size of the main vessel and its branches is of utmost importance in such trifurcation and multiple branches cases. Hence, imaging, IVUS or OCT, whichever is available at the center or the operator is comfortable with, plays a real pivotal role. Proper lesion preparations, not to mention with appropriate tools, is a must, not only for short term, not only for negotiating those lesions at that time, but also we understand for long term results. Also, rotablation in angulated and tortuous lesions really required patient multiple runs, avoiding any forceful pushing, because that can lead to perfusion, which we have seen at our center also. Thank you all for patient.